So we're starting to place our prop bite block, and we see that we're going to extract this partially erupted 3.8 with a particular curvature of the mesial root. We will start with local anesthesia, articaine with 1 to 100,000 epinephrine concentration of vasoconstrictor, and we're going to slowly infiltrate the area in different points to obtain the complete anesthesia of the area. So we see that we're trying to stretch the tissues with our retractor, and we slowly introduce the correct amount of liquid. We're then going to place some more anesthetic in different points, and we will choose the distal part of this 3.8 tooth, and we're also going into the lingual sulcus, and we can see a bleaching of the superficial tissues, which shows us a good infiltration of the area. Always do it very, very slowly and take your time to complete the anesthesia and the anesthetic protocol. We're going to follow the peripheral area of the tooth, giving time for the liquid to spread through the tissues. Here is the mesial part where we had the majority of inflammation, so where we're going to have the most inflamed part, and we're going to try to infiltrate touching the bone, so going to the periosteum with our anesthesia. We can see that the anesthetical procedure takes more or less 3 to 4 minutes for it to be completed. We see that when we infiltrate the soft tissues, sometimes we have some production of exudatum which comes out from the sulcus. So this is the design of the flap: intrasulcular 3.7, 3.8, and then a releasing incision in the distal aspect of the flap. A 15C blade, intrasulcular, to feel the bone. These type of teeth, which have a partially erupted appearance, will also have quite a inflamed peripheral area around the tooth, and that area is the area which is usually a little bit more difficult to elevate. So full thickness, we see that we have diverged distally and buccally with our releasing incision in order to avoid any issues with the lingual nerve, and then on the lateral last part a semi partial incision of the soft tissues. Then with our elevator we are using a freer retractor, and we're trying to find the bone layer in order to elevate a full thickness periosteal flap. And so this is the most difficult moment to find the correct separation plane, and then once we find it, we can see that we enter with our freer and we push and pull towards the buccal aspect of the flap in order to elevate a full thickness flap, trying to maintain the integrity of the periosteum of the rest of the flap. and this is one of the good bases to have a good healing. On the distal part, we're going to have some soft tissues which aren't very compact, so not so easy to separate, but once we find the correct separating plane, we're going to have a good result. And we can see that these tissues were quite inflamed because of the bleeding of these tissues. Okay, so we're going to go distally, but we're not caring a lot on the distal part because our axis is going to be completely on the buccal aspect. We have seen that this tooth had a periodontal pocket on the buccal aspect, and so after a good cleaning, always remember to clean the surgical field to see as best as we can the area. We're going to use a piezoelectric insert to create a working space around the buccal aspect of the tooth. This is an EX1 insert, but we can also use a Fisher burr. So we're working around the tooth, trying to create some space, avoiding the removal of too much bone, which is vital for the good post-op of our patient. So we're going around with this EX1. We can see that we're using this insert as if we were drawing with a pen around the tooth. We know that this has a selective cut, so it won't cut the soft tissues. We're seeing that the insert is touching the distal lingual soft tissues, but is not creating any problem whatsoever. So we're going around on the mesial aspect, on the buccal aspect, and on the distal aspect to create a space for the tooth to move. Once we have made this procedure, we're ready to sample the mobility of the tooth. So we're trying to luxating the tooth in a mesiodistal aspect, and we see that there is a little bit of movement, and also in a buccal lingual aspect. But we know from the anatomy that we have seen in our x-ray that we're going to need to cut the tooth in different aspects in order to remove that curvature, that big curvature of the mesial crown. So we decided to remove the crown from the root, and so we're going to have a horizontal cut parallel to the CEJ in order to remove the crown. In these cases, the patient can feel a little bit of sensitivity, and so we're going to apply more anesthesia in a intrapulpal anesthesia. We're going to complete the partial odonto section, dental section of the crown with our Fisher burr, remembering not to complete the cut on the lingual aspect. A good hint is to look at the length of the head of the burr and to see how much the head of the burr enters our tooth. So we're going distally. Always remember to remain parallel with our retractor. In this case is a Langenbeck retractor, in order to avoid any damage to the surrounding soft tissues. So always remain protected in the same axis between the Fisher burr and the retractor. So once we feel that we have made a correct cut, then we are ready to complete the separation with a fracture, with using a lever. So here we're seeing that we weren't completely efficient with the cutting of the tooth, and so we are completing a little bit more the sectioning of the tooth. With a straight, thin lever, we're going to enter the tooth and we will create the tooth fracture. The tooth is partially impacted in the distal aspect of the second molar, so we're going to separate the crown into parts, going from a buccal area to the lingual area of the tooth. So we see that we're cutting the tooth. We're cutting the tooth in order to remove the two fragments. Once we have done this technique, we're going to separate the two fragments and we're going to remove the distal aspect using a clemmer tweezer. The distal part has been removed and now we can remove the mesial part of the crown. This is the area where we have the adhesion of the inflamed soft tissue, so it's going to be a little bit more uncomfortable to remove. Now we're ready to access the roots. Always remember to clean, because after we cut the tooth we're going to have some teeth fragments and we want them to be completely removed. So now we're ready to create a separation between the mesial root and the distal root. We already know that since we have that big curvature, we're going to remove just the more coronal part of the mesial root, and we're not going to be able to remove the apex of the root. But the fact that we have luxated previously, before doing any tooth sectioning the tooth, is going to help us to remove the apical part of the root. So always remember to remain inside the tooth and not to cut the tooth on the lingual aspect unless you use piezoelectric instrumentation. Now, once we have proceeded with our tooth sectioning, we can create the fracture of the distal mesial aspect. And now we're ready to luxate or try to find the movement of the distal root and of our mesial root. We see that there is some movement, but there is still some blockage of the distal part of the root. So we concentrate on the mesial part, on the not the complete mesial root, but on the coronal part of the root. And with gentle and prolongated movements, we're going to remove this part of the root. And as we already knew, we can see that the apical part of the root is still in the alveolus. So now we can see and we can wash and rinse to remove any fragments, and we try our luxating of the distal part, and we see that there is some movement, but we don't have to insist. We just see that there is some movement and we have to create more space. So using our piezoelectric insert, we're gonna cut, keeping in mind that we have to keep the axis of this insert towards the tooth in order to cut some of the dental structure, avoiding to remove too much bone surrounding it. But we can see that also going distally and touching the soft tissues, this won't create any kind of problem. So we're going to work around as if we had a pen around our tooth, something that we can't do with a normal fissure burr. So now we enter the space with our straight lever and we start luxating in a distal mesial direction and in a buccal lingual direction. And this slowly will create an expansion of the surrounding bone, helping the final part to be extracted. We decide to create a further separation of the two fragments of the roots going in the septum, and we're going to work with loops. We're working with eye loops to have a major magnification. So we're working around our tooth, creating some space for these two fragments to be extracted. Once we have created the correct working space, we can also approach the area with smaller levers in order to arrive a little bit more apically and have a better axis of the force. We see that the root is now moving much more easily than before, and we know that we are on the correct way for the extraction. Always remember to apply long and gentle forces. We don't have to extract the tooth with a force, but we have to follow what is the correct bone peripheral, the peripheral bone expansion. So we see that the distal part of the root is coming out, and we have the extraction of the distal part of the root. So now we have to concentrate on the last curvature of the mesial root. So we have to decide what is the correct way to remove this root, and we're going to create a little bit more space in the septum of the root. So we're going to remove some of the bone septum in between the two roots, and this is easily done with the piezoelectric instrumentation. So once we have created the first cut, we go into that small cut with a very delicate and gentle lever. Always remember to look and to remove these bone and tooth particles that we can leave inside of the socket. We have changed the insert. We have now used a saw-like insert that cuts a little bit more and creates a little bit more space between the septum and the root. We have to know that this insert is 0.3 millimeters of width, and so it is very, very gentle but very, very effective. We don't have to use it as a lever, otherwise it will break. And we see that the root fragment is now moving a little bit its way through the space that we have created. So we remove a little bit more of the bone septum between the two roots. And once we have removed this small septum, the root fragment is now on its way to be extracted, and with a mesial distal push, we are luxating distally that curvature which we saw on the radiographic X-ray. Slowly and prolonged movements and luxation movements distally, and now we are ready. Once the fragment is out of its final socket, we are ready to remove it with a little bit more movement, and now we have, with our suction, the possibility to remove the root fragment. Now it is very important at this level to go and completely clean the extraction socket, the alveolus, with a Lucas spoon, going distally on the distal part where we know that there was inflammation and we know that there was probing, so that tissue has to be completely removed. And we do this by scraping the spoon distally on the distal part of the root. We can use some curettes, and once we have removed it, we use some pliers to move the soft tissue gently and to detaching it from the rest of the surrounding soft tissues. So now we're removing, when we're checking out that all the soft tissue fragments have been removed, and then we have to concentrate on the rest of the alveolus. We see that there is a very small bony fragment that we have to remove. So we remove this small fragment, which could be one of the healing issues of this patient if we didn't remove it. And we have to thoroughly wash this area because some small fragments may remain inside of the sulc of the alveolus, and these could lead to an infection. So always check, and you see that by washing thoroughly, a small bony spicula was detected and removed. So always check thoroughly, take your time to look inside of the bone cavity. And then we have to check to see how our soft tissues go back in their original position. We check inside the alveolus, we check inside the socket to see that everything is clean, that the alveolus is bleeding, so that we have a good bleeding of the cavity, and in this case that the tooth was partially erupted, so we're going to have a healing, a second intention healing and not a primary intention healing. We apply a slow resorbing collagen sponge which will stabilize the clot and will also avoid food debris to collapse inside of the cavity. We are using 4.0 resorbable suture, and we're doing our mattress suture in order to close and seal the distal part of the second molar. This is a important suture for the good healing of the periodontal tissues around the second molar. So we see that by closing our knots, the two structures, the two soft tissue structures, will tend to close and get very, very near to have a complete sealing of the distal part of the second molar. We cut our two sutures, and we're ready to put single normal sutures for the distal releasing incision. So we're ready for the first suture, and we always try to follow the anatomy, the original anatomy, in order to reduce any scars of our healing. Okay, so we proceeded with the second suture and then the last one to close the apex of our releasing incision. And as we said, we're going to leave a little bit of open flap in the middle where the tooth had already erupted, not to have any tension in our healing. So now we are ready to place our cotton tissue in order to have the hemostatic effect. And the surgery is over.